Good afternoon to everybody. Welcome to this session. I'm going to introduce my co-chair, that is Soledad Ojeda from Spain, and the panelists that are Tom Johnson for UK, Joanna from Netherlands, Dr. Sheiban from Italy, Jozica Sikic from Croatia, and Francesca Sanguineti for France. Carlo is not here, no? No. So this session is a case-based session, is regarding bifurcation left main PCI in patients with high-risk bleeding. And you have the possibility to vote. It's really important because the winner will be based on your votes. So the first speaker is Joelle Kefer, and is going to present the 1-month dual antiplatelet therapy after left main and not left main bifurcation stenting.
Good afternoon, everyone. Thank you to the organizer for inviting me to talk about short DAPT after bifurcation stenting. So this is a case we encountered last year about a 77-year-old woman with a history of cancer. So we discovered an esophageal cancer in November 2023, and the plan was a curative treatment, chemotherapy, radiotherapy, followed by surgery. So in oncology, timing and sequence are of paramount importance to reach a curative approach. So she underwent chemotherapy, radiotherapy up to February, and then the esophageal surgery was planned in March 2024. She complained of typical chest pains. She underwent stress echo showing inferior ischemia and then coronary angiography, demonstrating 3 vessel disease. I illustrate here the left coronary tree. You see, you can appreciate the diffuse disease of the LAD with a distal lesion involving the bifurcation with the second diagonal branch. The main segment and the ostial LAD was diseased as well, involving the bifurcation with the distal left main. You can appreciate the abnormality of the DPR and FFR at both levels. And the right coronary artery had a focal significant lesion on distal segment. At this stage, we discussed with the oncologist, referent cardiologist, and patient before of the crucial sequence and timing for the surgery for cancer. We decided to treat these patients by PCI and not with surgery. So we treat in the same session the right distal artery with a drug-eluting stent, straightforward PCI. And we, 3 days after, doing a workshop, we treated the left coronary system. So you see the setup, radial 6 French, guiding XB3, wiring was easy, but the IVUS probe didn't cross the distal segment and the mid and distal segment of the LAD, so we need a predil to perform the IVUS investigation. We start with the bifurcation of the LAD and second diagonal branch, which is a Medina 111 with a provisional stenting pod side pod. So we predilate 2.0, the 2 branches, implantation of a drug-eluting stent 2.25, 18 across the diagonal, and the pod you see on the third panel that there is a severe pinch of ostium of the diagonal with a normal flow, but due to the severe lesion at this level, we decide to rewire side branch opening and repot. And you see on the right part of the slide the final result, which is not perfect but acceptable. Then we treated the distal left main, Medina 110, once again with provisional stenting approach. You see the dimension obtained by IVUS for the ostial LAD at 3.6, left main 4.9. There was calcium, but not circumferential. The QCA showed 4.4 millimeter for left main, and the mid LAD, which was the target distal landing zone, at 2.9. So according to all these measurements, we selected a non-compliant balloon 3.0 to predilate the LAD. We implant a drug-eluting stent 3.538 from the left main to the LAD with a short overlap with the just previously implanted stent. You see just in the middle of the slide the positioning of the stent by a stent boost. And you see after the pod at 4.5, the final result on the right part of the slide. So we decide to accept this result with no pinch of the side branch, good flow. So we did not recross the side branch, we just accepted the result with a pod. So you see here the IVUS after the PCI of the left coronary artery. We check the good apposition. We observe the partial underexpansion at the level of the LAD, which was fixed by repeated non-compliant balloon and high pressure. And after 1 month of this procedure, we repeated a systematic follow-up angio showing patency of the stents and the good IVUS result. You see here the different levels of MLA of the left main, LAD, and one coronary artery. So after 1 month, we stopped the clopidogrel to allow esophageal surgery under aspirin single antiplatelet therapy. The surgery was uneventful, and we restart the clopidogrel after the esophageal surgery. You see here the angio of the left coronary tree at 1 month, and you can appreciate the images obtained by IVUS in the left main with an MLA around 20 millimeters square, and on the LAD around 8.4 millimeters square. This is the pullback of the IVUS at 1 month. So once again, we pay attention to reach a good apposition, good expansion, especially at the level of the overlap and of the left main. And after this check, we were reassured and we stopped the clopidogrel, allowing the cancer surgery. The patient came back 8 months later for atypical chest pain, so suspicion of angina, but we repeat the angio, which showed a very good result at all levels, patent stents and normal flow. And the last clinical follow-up was obtained after 2 years in April of this year, which was very good from the cardiologic and oncologic point of view. So the take-home messages of this case are we would like to illustrate the safety of a very short DAPT 1 month after stenting a 3-vessel disease, including 2 bifurcation, left main and non-left main, using a provisional strategy. We used only 1 stent at each side, so a minimal amount of metal, IVUS guided. We planned a systematic angio and IVUS control before to stop clopidogrel. The non-cardiac surgery was performed under a single antiplatelet aspirin in this high HBR patient. The timing and the sequence are crucial in cardio-oncology. It's important to work in a multidisciplinary approach. And finally, the design of the last generation drug-eluting stents and optimal bifurcation technique allow to treat these complex patients using modern interventional cardiology. Thank you for your attention.
Thank you very much for your presentation. I think an important point of discussion is the strategy, because obviously the result was perfect, the patient is okay, but maybe the length of stents is very long, taking into account the high risk of patient. Or maybe in this scenario, a good option would be drug-eluting balloons to treat a very diffuse disease in LAD. Maybe it's a good point to discuss.
I don't know, I'm thinking all the time, what do you think about only DCB strategy? Because there is too much struts inside, and you have overlapping, and you have also bifurcation part, and you have a crash part in the main and the side branch. So did you think about the DCB only?
Yes, it's another possibility. So this case occurred 2 years ago. So at this moment, we were not so comfortable with the drug-eluting balloon in our center. On the other side, there's a large amount of calcium in the vessel, so maybe we were afraid a little bit about the suboptimal result with the drug-eluting balloon. But today, if we should repeat this case today, so in 2025, maybe we will discuss drug-eluting balloon, which is another good option, I think.
A question for the panel and Dr. Kefer as well. Do you think that follow-up with OCT imaging might help to confirm good endothelialization of the struts and confirm that DAPT interruption is safe?
I think it's a good question. I think at 1 month, most of the stents, current generation stents, have about 90% coverage, right? We don't know if it's endothelialization or if it's just coverage. But it might be more reassuring. I mean, this IVUS was a little bit low resolution, so it was more, I think, to see that it was good, well expanded and well opposed rather than to see more detail. And I think, you know, this is a very difficult case because this is an oncology patient that has to be operated upon. I think if you took that out of the equation, you would say switching to aspirin monotherapy is probably still carries some risk, even if it's after 1 month, and you would switch to maybe clopidogrel monotherapy with genetic testing or another drug.
Yeah, actually, I think stenting in this case should be preceded by very good lesion preparation, IVUS guided, intravascular imaging guidance. But also I think that combination of hybrid approach, that means drug-coated balloon where it's possible to use, I think could be a very good option as well.
Yes, I agree with you as we discussed just before, but once again, this case occurred two years ago, and at this stage we were more confident with drug-eluting stents. As pointed by Joanna, we know you are using new generation drug-eluting stent after 1 month. 95% of struts are covered, especially in case of optimal results by IVUS, so we were confident with the tools we used every day.
Yeah, I mean, the focus here, Joelle, it's a lovely case, and I'm interested you use Ultimaster stents, and obviously the evidence with Master DAPT supports potentially a 1 month cessation. Yeah. But the focus very much with the discussion at the moment is the high bleeding risk potential of the patient. But by being also a cardio-oncology patient, they also have a thrombotic potential. And so minimizing the stents, and whether that's actually medically treating some of the lesions or DCB or avoiding or minimizing length of stent, I guess is a consideration. So you've got a beautiful result, but I guess through the discussion there are lots of different ways this could have been managed.
Do you always use imaging to follow up a patient in who you want to shorten the double dual antiplatelet therapy?
Yes, I think we would be more confident to just with an NGO follow-up at 1 month is not enough. So we just would be really reassured by IVUS or OCT confirming the good apposition, the perfect expansion, especially at the level of the short overlap. I don't recommend to do systematic NGO and IVUS follow-up after all PCI in HBR patient, but in this specific situation with you should stop clopidogrel, you should not stop aspirin, you should stop clopidogrel for the esophageal surgery. I think we could recommend this approach.
Thank you. We have to move to the next presentation. Thank you very much.
Thank you.
The next presentation is ROTA-TRIPSY in acute coronary syndrome in an octogenarian patient, and the presenter is Dr. Kalia.
Good afternoon, respected chairpersons and my dear friends. At the outset, I would like to thank Chairman EBC for inviting me for this symposium. Today, I'll be presenting a case of ROTA-TRIPSY in ACS in an octogenarian patient. So basically, my patient was 82 years old female. She was a known case of ischemic heart disease, post-angioplasty to RCA and LAD done in the past. And she was hypertensive as well, non-diabetic. She was admitted to our hospital with unstable angina. Coronary angiogram done showed 90% ostial calcific stenosis, LCX stenosis, with heavily calcific distal left main and osteoprox LCX. At that time, because of the advanced age and complex procedure, patient and the relatives denied, so they took discharge. So we discharged her on DAPT, anti-anginals, and statins. However, she was readmitted to our hospital with massive lower GI bleed. She required multiple blood transfusions for the same. The lower GI endoscopy showed anorectal ulcers, for which she was treated by a gastroenterologist. So we had to stop DAPT for a few days. However, we did restart aspirin because of the critical coronary artery disease, which was not addressed after 3 days. However, patient, to our misfortune, she developed ACS on day 5 of the second admission. ECG showed fresh inferiolateral changes. Echo showed LV ejection fraction of 35%, inferiolateral hypokinesia, and moderate mitral regurgitation. And she was having some CCF, so we had to treat her for 24 hours, and we stabilized, and her creatinine was normal. Then we planned to take her up for angiogram. Since we already knew the coronary anatomy before, which was done just 2 weeks back, the L6, which was 90%, now you can see it is totally 100%. And on ariocaudal view, you can see the proximal L6 is heavily calcified, and you can see eccentric indentation on the left main, distal left main. In elaeocaudal as well as ariocaudal, you can see this probably there must be some calcium chunk, which this is what I thought because she's 82 years old. RCA was stented previously, which was normal, and our LAD stent was also appeared to be all right. So what should we do now? This is complex calcific left main bifurcation, PCI Medina 101. What should be the strategies? Since it's a complex, obviously imaging has to be used. Should we go for LML6 provisional, or as the discussion has been going on with the previous case, whether we should do DCB in this case? Now, we have to use some kind of calcium debulking strategy, definitely, whether it is cutting balloon or rotational atherectomy orbital or IVL balloon, or we may have to use some device combination as well, because usually in calcific, single device doesn't suffice. So first we thought of doing for pullback, because whether we go for provisional or we go for bifurcation will depend upon what is the status of the LAD ostium. So here you can see the stent is all right, and there is a calcific plaque in the left main LAD ostium. However, the MLAs are good, and here the LM diameter is 4.5. So we know we are dealing with the big size discrepancy, 4.5 LM, and LCX we would not know. We'll do the imaging for the same. And also in the L mode, you can see lower down, there is a calcific nodule protruding in the left main. So we are dealing with calcific ostial LCX and the protruding nodule, calcific nodule in the left main. So since it was a very tight lesion, we pre-dilated with a semi-compliant balloon, just 1.5 by 10, just to make some space. Then took a ROTA, 1.5, multiple runs, 160,000 RPMs. After that, you can see This is the angiogram on the right side, aleocaudal. The lesion, of course, the LCX is open, which is reasonably good size. But however, I was not very much convinced about the lesion preparation of the LCX. So we took OCT run from LCX to left main. You can see the distal LCX, some calcification is there, but the distal reference diameter is about 3.25. There are ostial dissections post rotablation. The lesion is still tight. And in the left main, you can see the right upper panel, there is a still calcific nodule which has not been very well prepared. This is what I thought. And at this point, if I just straight away go and deploy the stent, I may have stent under expansion or malapposition, which can lead to high ischemic risk or target vessel failure in future, because we are dealing with the HBR patient whom I want to stop the DAPT as soon as possible. So in this situation, as Dr. Imad pointed out, that we need to do lesion preparation very well before we do the stenting in these cases. So I thought, and also when we did the pre-dilatation, in one of the angles I could see that the balloon is not very well expanded, because we have to take two orthogonal planes. And also, as Professor Sheiban, again I will quote him, because he came to Mumbai and he said that if you do stent boost, it is poor man's imaging. So here on the second image, you can see still the LCX is the heavily calcific LCX we can see. So I plan to take IVL balloon for the calcific nodule in the left main. So 3x12 IVL balloon, multiple pulses were given, 80 pulses. Then after post-dilatation with NC balloons, serial NC balloons, LMLCX was stented with Zions Sierra 3.5x23, because 3.5 would grow up to 5.5 because it is Zions. Pot was done using 4.5x6 NC balloon. And then because it is LAD, there was no stent there, and so I just recrossed it, and we did low pressure kissing and repot of left main, because we wanted the patency of the LAD, because we have a stent across the native LAD. So this is the final result we got. You can see in aleocaudal, it was a wide angle LAD LCX. The left main is very well open, and there is good TIMI3 flow in both the vessels. Unfortunately, because there was a stent at the ostium, we do not have very good clearing of the dye in OCT. I would have preferred IVUS in this case, but our IVUS machine did not work on that particular day, unfortunately. And from the imaging, the areas we got for the distal LCX was 7.15, ostial LCX up to 9, and LM I got 15. MSs, 15 millimeter square. So these are the good MSs wherein, I may be able to stop the dual antiplatelet therapy earlier because of the high bleeding risk in this patient. So the take-home message in my case is stopping of DAPT can precipitate ACS. LM calcific nodule and circumferential deep calcium may require more than one calcium debulking strategies. Imaging-guided PCIs has to be done in left main and complex heavily calcific lesions to assess which strategy would work best. In elderly high bleeding risk patients, shorter DAPT is preferred, and precision PCI, today what we are calling the imaging-guided PCI, would help us in achieving good short-term and long-term outcomes. Our elderly patient was given dual antiplatelet for 1 month, aspirin and clopidogrel 75 milligrams each. And after that, I shifted her on aspirin only 75 milligrams. And since 18 months, I've got a clinical follow-up with this patient, and she's doing very well. Thank you for your attention.
Thank you. Any question from the panel? Any comment?
Well, actually, in this case, the culprit lesion was circumflex.
Yes, sir.
So what I see from angio, not from intravascular imaging, I think in this case, he was bleeding just a few days back.
Yes, sir.
What do you think about limiting your procedure only on circumflex and then follow up? And after that, if he will be more safe to perform another procedure with, if needed, with stents.
Just opening the LCX?
Yeah, just open the LCX, the LCX, circumflex.
Yeah, so we did LCX, but it was very difficult to nail the LCX ostium because there was a calcific nodule in the LCX, the distal left main. So distal left main, 60% lesion, I could not have left. And nailing this particular would have been very difficult.
Yeah, but actually after rotablation, I think you can try, after dilatation with balloon, after rotablation, if you get good lesion preparation, you can go also with drug-coated balloon.
Yeah, drug-coated balloon was a thought first, but because we have to leave the left main nodule without addressing, and in calcific lesions, I mean, the drug-coated balloons uses...
No, actually what you did is excellent. But I'm talking about another option.
Yeah, option, yes. But because it was calcific, it was a bigger vessel. The LA, I took 3.5 stent, went up to 4.5. So in larger vessels, drug-coated balloon versus stents would do equally well. Stents would do rather better, I would say. And since I got MSAs very good, so I thought peacefully and a good stent. Currently, we are having really low thrombotic risk stents with Xans, and as we know, master DAPT also we have stopped, and precision PCI with imaging guided would help us to achieve the best results, and which is doing.
It's a question of being comfortable with DCB and the left main, and I mean, I think most of us are still learning the technique and how to do this actually. So, and the trials are still pending. So, I think to optimize this for the patient, you should do the strategy that you feel comfortable with, and you did a really great lesion preparation, and you got a good result. I mean, I think putting things off, the bleeding risk for this patient is not going to go away. It's usually this thrombotic risk is higher in the first month, but the bleeding risk keeps on going, right?
Yeah, but I am thinking about what I should do if patient will be coming back for bleeding. That is the question.
There is a question.
Circumferential calcification, the rotablation can do the job, but for calcium nodule, I noticed that IVL is much better.
Exactly. In calcific nodules, you need either orbital or you have to have IVL, calcific nodule. Circumferential, that's what. So our patient had both. In left main, he had nodule, and in the circumflex osteoproximal circumflex, he had circumferential calcium. So that's the reason I had to use both the strategies in the same patient. And probably orbital could have done job better than this. We did not have orbital at that time. So, it's like one stop, this thing for such cases when we have both the things, orbital and retrograde osteal, excellent. Second modality, which I would have done probably just taken orbital, and I didn't have to use two different calcium debulking strategies in that case.
I think you did a perfect job. After the war, everybody are generals. But the main thing is because usually when we do ostial stentings, we are avoiding playing with the catheter not to crush the proximal starts of the stents. Usually in my cath lab, we put the Godzilla catheter inside of the wire, and you push, we made it 30% saline and 70% contrast.
Yes.
And with the Godzilla, you can make a very good picture on the iris.
Yeah, the last frame.
This is for the last.
Yeah. For the last picture, yes. Since the left main was very short here, I had to take pot balloon 6 millimeters. So whenever we have very, very short left mains, it is very difficult. If you have long left mains, then definitely I would have used, guide extension catheter to take pictures as well as for the even stenting. Definitely, we have used it in our cases, but it was too short left main. Thank you.
Do you have experience with orbitaling in this scenario?
Yes, I have used orbitals in maybe 4 cases of left main and LCX ostium, another case. Similarly, that this patient had very tight circumflex and very big calcific nodule sitting on at the junction of left main and ostial circumflex. But here in orbital, when we are doing for the circumflex especially, try to do it retrograde first, so that you don't perforate, because that's very easy because there would be the bird jump On glide assist, cross the lesion and come back. Do multiple retrograde and then you can do antegrade once you have made some space. Because with orbital, you will get more luminal gain compared to ROTA. And if you have to use ROTA in calcific nodules, you have to increase the burr size from 1.5 to 1.75 because the luminal gains are not great with ROTA. ROTA, however, excellent tool for balloon non-crossable lesions. When you have small vessels, I would prefer ROTA. Big vessels, proximal vessels, big nodules, orbital would be my first choice, given in any case, because it gives huge, very good luminal gains. And there are micro cracks in the deeper layers also. So you don't have to use many more calcium debulking devices further, like, after that OPNNC or, cutting balloon, you don't have to use. You get good luminal gains, straight away NC balloons and stent it. That's what my experience tells me about orbital.
Okay, thank you. You need to move on.
I'll just comment that orbital is not really that obvious to use because orbital will go to the area of minimal resistance. And when you have a nodule, it's really not an obvious choice.
No. You can use orbital when you have a tight lesion.
Correct.
So if you have a larger luminal areas to begin with, orbital doesn't work because you are just orbiting in the air.
Correct.
But if you have tight stenosis, I'm not talking about balloon non-crossable.
We're until
tight lesion, so even Ziad Ali has shown in his cases that tighter the lesion and with calcific nodule, orbital works best. If you are a big lumen, the orbital would just orbit in the air. So it doesn't give you much luminal gains if you have a larger lumen to begin with. So at that case, in such cases, you should use IVL. That's ideal because you have good lumen. IVL do the job of creating deeper calcium cracks in big vessels.
Again, IVL in nodules are not that well suited.
I know. But if you have larger lumens, probably you should use.
Correct.
Thank you.
Thank you.
So the next speaker is going to present the change in the treatment paradigm by Mila Kovacevic.
Okay. Dear Chairman, dear ladies and gentlemen, it is my great pleasure to participate in this meeting, and I would present a case, as you can see, titled Bifurcation or Trifurcation PCI in patient with high bleeding risk. Just to see whether... So this is a case of a 62-year-old male patient who was admitted for scheduled PCI of LAD and Ramus due to the symptoms of unstable angina. His risk factors are hypertension, dyslipidemia, and diabetes. And on admission, the patient brought his medical history, and there was a recent gastrointestinal bleeding due to diverticulosis, and his blood count was hemoglobin level was 97 on admission. However, in this medical history, there was, according to the gastroenterologist, no treatment was needed at that point. Echocardiography showed preserved ejection fraction without wall motion abnormalities. So you can see this was his angio. As you can appreciate, there is left main trifurcation lesion, 0101, and there is also diffusely diseased LAD. You can see also that there is a distal LAD stenosis, mid LAD stenosis, ostial LAD stenosis. There is also bifurcation LAD diagonal, and this clear left main trifurcation. So the question is how to proceed with this patient. He's obviously high bleeding risk patient, not patient with carcinoma, but the patient who has diverticulosis and recent bleeding. And the question is, maybe we can discuss now or later, if you want. So first of all, there is one possibility, cabbage, obviously not suitable because there is a distal LAD stenosis, so there is not good distal target for cabbage for Lima. The second option is PCI with drug-eluting stents only, so there is left main trifurcation lesion. We should go from crossover stenting from left main to LAD, then possible TAP for Ramus. And also drug-eluting stent in distal, mid, etc., LAD. So several stents would be needed. The third approach can be hybrid approach, drug-eluting stent and DCB particularly in periphery, and maybe the drug-eluting stent for left main trifurcation, and the fourth option is DCB-only strategy. So our thoughts was to start with the DCB and to see, like, either to proceed with hybrid approach or just DCB only. So first, we started with the Ramos intermediate branch. We did pre-dilatation with 20 millimeters semi-compliant balloon, then DCB 2.5, 25 millimeters, and you can see this is the final result of Ramos. Then we proceeded with a pre-dilatation of all LAD, first distal, then in mid and proximal part. You can appreciate the sizes of the semi-compliant balloon. This case was done 2.5 years before, like it was February 2023. So nowadays I would do maybe differently. I would maybe be more aggressive with not 2.520 on this proximal or mid LAD, but I would go with a bigger balloon and not maybe semi, but NC balloon. And then also proceeded with the distal LAD with the DCB 2.2530, then mid-proximal LAD with 2.525, and then ostium of the LAD with DCB 3030. As you can appreciate, this is the final result. There is non-flow limiting dissection in mid-LAD type 1. There is also non-flow limiting dissection in Ramos intermediate branch type B. However, at that point, we were satisfied with the result. So there is non-flow limiting dissection. Residual stenosis is about slightly more than 30%, but we were satisfied with this result. 3 months later, we did a follow-up, but we proceeded with the butamine stress echo and coronary flow reserve. The butamine stress echo was negative, and also patient was free of angina symptoms, and the CFR was also good, 2.76. 6 months later, we also proceeded with the scheduled control coronary angiography, just due to the curiosity, even though patient was without any symptoms. So this was his angio at 6-month follow-up. As you can appreciate, maybe it's not perfect result, but there is TIMI3 flow in all branches. And also, what is very important is the distal LAD is very good. There is no stenosis at the distal LAD, so this patient can be a candidate for future CABG or Lima. Also, maybe curiosity is something that drives us. So we did also functional assessment, just to be sure for this LAD, because also this is a left main trifurcation disease. And as you can appreciate, the DPR in mid-distal LAD was 0.90. However, the most important is that the patient didn't experience any symptoms, any angina symptoms in the past 6 months. So according to these results of non-invasive assessment, CFR, and invasive functional assessment, and due to the absence of angina symptoms, just optimal medical therapy was proposed for this patient. So this is 6-month follow-up, but the patient was 1 month on dual antiplatelet therapy. And what can I say in conclusion? We all know that now DCB, it's not a novel, it's now standard alternative therapeutic strategy. And other than in small coronary vessels, DCB can be successfully applied in de novo bifurcation, trifurcation lesions, and also multivessel disease like in this patient. And maybe it can change the strategy for future PCI or CABG. And of course, in this particular patient, considering a complex anatomy for stenting, left main trifurcation, which was not suitable for CABG due to the distal LAD disease, and not favorable for multivessel stenting due to the high bleeding risk, with this DCB-only approach, we managed to to accomplish good result, which will enable like future PCI or Lima LAD if there is a progression of the coronary disease, particularly in proximal or mid LAD. Thank you.
Thank you.
This was very nice. Could you just tell us, you already mentioned some of the elements that you go through in your head when you assess the effectiveness of your DCB strategy, or actually predilation before you apply the DCB?
Yes. In this case, really was done in February 2023. So in that time, I was very cautious, like performing DCB-only approach. Nowadays, I do it more like really maybe a bit more aggressive than 2 years ago. Maybe I would choose, although we have now also randomized data that shows like that there is like non-inferiority of sirolimus balloon, maybe nowadays I would do with the paclitaxel balloon. But at that time, it was like we had the DCB, a sirolimus-coated balloon in different sizes. That was like the reason I chose at that point sirolimus balloon. Nowadays, maybe I would do with aggressive predilatation, particularly in this mid and proximal LAD, because mid LAD is not 2.5, it's probably 3, and the proximal LAD probably is 3.5 in diameter, so I would go with an NC balloon and in larger diameters of balloon.
Yeah, just to extend, it was a beautiful case, Mila, but to extend that, there's that jeopardy between causing enough injury and sufficient lumen gain against creating dissections that push you towards having to cross over to stenting. So you were cautious, and 2.5 ballooning of the whole of that LAD resulted in an acceptable, maybe not a perfect, but an acceptable result.
Yeah.
And then what's interesting to see is when you then come back and undertake physiology at a later date, actually the physiology is achieving what's required. So that's a real challenge in terms of how you shift from what we look for as perfection with a stenting result against acceptable with ballooning. So I was interested to see you went 2.5 along the whole length, but then you went 2.25 application of drug distal and 3.0 proximal. So there was jeopardy in the sense of oversizing with the drug treatment when you may then cause dissection that undoes all the good that you've achieved. Has that practice evolved in your time since this case?
Yes, I really aim to do proper predilatation, and as we all know, like dissection is something that we aim for, like for dissection, because in that way we are capable to deliver the drug into the vessel. So the proper dilatation, I don't like to see like dissection especially not in mid proximal LAD, but we know that it's not something that we have to be afraid of, like to have dissection. And also, yes, you mentioned, yes, I did predilatation 2.5 and there was dissection. So maybe if I did with a 3.0 balloon, maybe the section would be worse. So we never know how the particular patient is going to react, but maybe intravascular imaging could help. How aggressive should we be in this particular, not this case, but when we decide to go with DCBs, like to do like first intravascular imaging, and then to decide what kind of balloon, semi-compliant, non-compliant, scoring balloon, what kind of balloon can we use or should we use?
Mila, you have an excellent question, excellent case, but I have two basic questions. One is, did you correct the anemia, because we are talking about bleeding risk? Did you correct anemia before? And the second one, why you didn't use a functional test before you perform a DCB procedure?
So you could see maybe also that was impaired TIMI flow in this patient, particularly in the ostium of the LAD. So there was a critical stenosis of the ostium of LAD. That's why I didn't use functional testing before. Really critical, I could go back if you want, but the critical ostial LAD stenosis, this was most severe disease in this patient. That's why I didn't use functional testing. And first question was, sorry? A correction of the median. No, he was like 97 gram of hemoglobin level. So everything that is above 90, it's acceptable for cardiology patients. Not usually target 17, but in these patients, like 90 is something that we should achieve. Thank you.
There are two questions, one at the bottom.
Yeah, Franz Kleber. This was a really nice educational case. Congratulations to this case.
Thank you.
You've been not afraid to leave a result which is somewhat ugly, but as I always say, the cath lab is not a beauty salon. And you left especially the B dissection in the distal LAD, and you've not been afraid about the result. I think this is perfect. The only point I like to mention is you pre-dilated, I think it was the Ramos with a 2.0 balloon and then used the 2.5 DCB. I would rather take the same size.
I agree. Really, it was, as I already mentioned. And I have to mention that this case I did with Bernardo Cortese. He was that in my hospital, so we did this case together. And yes, I agreed, 2-0, we should go like 1-to-1 pre-dilatation for like lesion preparation. Yes, I agree. I would do differently now, but you could see there was dissection type A, so maybe it was enough with the 2-0 balloon. But I agree, I would go with a higher balloon now.
I think you did a great job I think you did a great job regarding the DCB for the ramus and the mid and distal LAD. But actually for the proximal and ostial LAD, I will feel reluctant to do DCB and without stenting. Anyway, you will give DAPT, even you're using DCB. You will give it DAPT for 1 year or 9 months at least.
Sorry, I didn't understand. You would go with the
stenting for the proximal LED only.
Yes, we could do this, but we are going into the complex PCI of the left main trifurcation. So we should go like crossover stenting from the left main to LAD, then two-step kissing or three-step or tracing or triple kissing, and maybe also bailout TAP stenting for ramus would be necessary. So double, like a lot of metal in the left main trifurcation and high bleeding risk patients. That's why. But of course, if there was compromise, the LAD ostium or LAD was compromised, I would proceed with crossover stenting.
I trained the airway, did balloons all the time, you know, and practiced before even stents came around. So this is the kind of results we'd leave alone. Patient did just fine. But what our change practice now is use intravascular imaging to size my balloons. I think that would be a better way to go.
Yes, I agree. I mentioned that maybe this is the best way to understand how to prepare the lesion. Yes, properly. To use different devices, tools, semi-non or scoring balloons. This one? Usually we do like pre-treatment, yeah, before.
Thank you very much.
Thank you.
Mila. We move the last presentation. The last presentation is left main PCI in high bleeding risk patient. Do we need a dual imaging system? By Aninka Saboe.
Good afternoon, everyone. My name is Aninka Saboe. I'm an interventional cardiologist, and today I'd like to present my case about complex left main PCI. I think this is the different slide that I gave to the. I already sent the different slide. Yeah, the title is left main PCI in high bleeding risk patient. I already checked in the morning. No. Yeah, it's okay then. You don't have? Yeah, okay. Okay, so this is a case of a 71-year-old woman. She came with our clinic to the hospital with non-ST elevation acute coronary syndrome at the anterior wall. She had history of GI bleeding and already underwent endoscopy. With the result is erosive hemorrhagic gastroduodenitis and treated by a gastroenterologist. From ECG, we found dynamic ST changes at the anterior wall, and echo, we found hypokinetic at anterior wall. From lab result, we found low hemoglobin of 10.5 with normal renal function. And we also found slightly increased troponin level. The day before, she already underwent coronary angiogram, which found heavily calcified severe stenosis at the proximal LAD and refused KBH. Therefore, we proceed with PCI. Okay, this is the left coronary angiogram. We can appreciate there are tram tract at the proximal LAD and severe stenosis at the proximal LAD. The circ was good and pretty large. And we proceed with IFUS from left main LAD. We appreciate there are calcified lesion, and there is also calcium nodule at the prox. But at the astial circ, we found there is eccentric lesion here up to the POC. Therefore, we proceed with orbital atherectomy with antegrade and retrograde ascending with low and high speed, followed by predilation with 3.25 cutting balloon up to 18 atmosphere. This is the calcification evaluation during pre-PCI, post-orbital atherectomy, and post-cutting balloon. We can appreciate there is good calcium modification. We can see reverberation, and at the post-cutting balloon, we can see there is good crack there. Therefore, we proceed with left main to LAD stenting and POT with 4.5 NC balloon. This is the IFUS evaluation. After rewiring to the circ, we can appreciate no stent H dissection and also the good stent expansion and apposition with good MSA at the left main and LAD. However, during the final shot, we appreciate there is pinching at the astial circ, and the circ is pretty large. Therefore, we decided to use OCT for better evaluation at left main bifurcation. This is the OCT pullback. And this is the 3D OCT analysis. We appreciate there is gel strut at the astial circ and the link connecting type at the carina. And therefore, we found gel wire recrossing position is suboptimal. And we decided to perform more optimal POT to change gelling strut configuration with 4.0 NC balloon. And this is another OCT analysis. This is the OCT analysis after re-POT. We found the carina configuration is now less gelling type, and we still found some gel strut, but with more optimal wire position. And this is we proceed with side branch dilation and also final POT. This is the final OCT evaluation, good stent expansion and apposition, and on the 3D bifurcation analysis, we found no gel strut and no stent deformation. This is the final result. There is no pinching anymore. We're pretty happy with the result. And we performed two-year follow-up. The patient was asymptomatic with a good result. And for the message, optimizing left main PCI requires meticulous stepwise approach, which we aim for result comparable to KBH. And the presence of gel strut may serve as a nidus for thrombus. And in this patient, particularly in the patient with high bleeding risk, where we need to minimize the duration of DAPT. And intracoronary imaging provides guidance for left main PCI optimization. However, each modality possesses different strength and limitation. And from this case, is it time to use dual combination intracoronary imaging for left main PCI? This is pretty like 5 years old study that published in Eurointervention, which describe about single catheter dual modality intravascular imaging. Thank you.
Thank you. Any comment?
Aninka, it was a beautiful presentation. I can't believe I'm saying it, but I wonder whether taking another imaging modality is a cost-effective way of dealing with the problem. But it's interesting that the trigger point, as I saw it, was that the ostium of the circumflex was pinched. But the primary rationale behind optimization was clearance of struts. Do you think the pinching is a surrogate for the stent struts, or are they two separate issues?
Okay, thank you, Tom. In this case, actually, the real presentation actually after we perform professional stenting, and then we found there is side branch and the circ is pinching. We want to know what happened in the ostial circ. Whether is it in a plaque shift or in a carinae shift or just strut. And then we perform IFUS to the circ, and we found no plaque. It's only jailing strut. Therefore, we proceed with OCT. Thank you, Tom.
Thank you very much for the presentation. Before, during the discussion, please vote to select the best case in this session. I have a question for you. Why the pot was made with a 4.5 balloon and the report with
4.0. Yeah. So we use the first POT is with 4.5, and the second POT with 4.0, because the second POT we can go slightly deeper, because if we use the 4.5 and we saw there's severe calcification at the ostial circ, we're worried we can have complication like perforation if we go too deep. But if we go deep with a smaller balloon, we are more. Yeah.
But the report was with 4.0 balloon too.
The second pot?
The report.
The report with 4.0. And the third pot is, the last final pot is with 4.0. It's just to reposition the carina. But the position of the left main is already good because we used 4.5 in the beginning and no malapposition.
And when you decide to do both, echo, IBUS, and OCT, in all cases with a lesion at the circ, or depending on the...
I agree with you. Usually it's more cost effective, as Tom asked, it's to use just one imaging, but as different imaging modality have different strength and limitation. In the beginning, we decided to use IFUS because it is simpler, because we know we're going to have several steps with classification, we need to evaluate, but IFUS cannot see the bifurcation morphology, and OCT, we can appreciate it more, so that's why the reason behind it. But it's really, really rare we use both of imaging in one case.
One question regarding orbital. After orbital, you did imaging and you see some nice cuts, but you decide to add a cutting balloon. Why was the reason? Was because you preferred to do a balloon and predilate more, or because your images was not enough plaque modification?
Okay, thank you. So from after orbital atherectomy, we see reverberation, but in some segment, we didn't see any crack. And we decided to use predilation with cutting balloon, while to see also is the balloon expanded well, because we want to see is there still any indentation during predilation.
And also there are some operators, they combine orbital and lithoplasty, but you prefer cutting balloon. Is your practice or?
Yeah, so actually in this case, because it has eccentric calcification, we still don't know which is the best lesion preparation strategy to perform in eccentric calcified lesion. But in my experience, my humble experience, I don't get a good crack using IVL in eccentric lesion. Also in cutting balloon, we also don't know, but we opted for the cutting balloon. So maybe more study is needed for eccentric calcification. What is the best way to prepare it?
Yeah, I think any operator maybe thinks different. Sometimes it's better cutting balloon, sometimes it's lithoplasty, so it's a good answer. Any comment?
Just while the comments continue, we've got 25 votes and at least 50 people sitting in the audience. So, and it's a tie at the moment for the first place. We've only got one trophy, so we at least need one more person or 4 more people to vote.
I have a general question to actually all the presenters. Many of you have brought patients back for re-angio, sometimes with IVUS and sometimes without. I mean, what's your trigger to do that? Is there any other less invasive modality that you would do to assess the result, long-term result of the left main stenting?
Oh, in my cases, we have registry in our hospital. So the patient, left main PCI registry, so before the patient undergo procedure, in the first procedure, we already ask for informed consent that the patient will do angio evaluation. And this is the patient with our registry.
So you're doing that in Indonesia or in MedStar?
Oh, this is in Indonesian cases.
Okay.
Yeah.
Well, I can tell you that I think
in the United States there are really, yeah.
No, but in Amsterdam, I think we also, when I worked there about 15 years ago, we were sort of regularly bringing patients back for re-angios after left main stenting, and we stopped because they all looked great. So there's, in my mind, there's no reason. If you do it, maybe do a CT scan.
Thank you.
I have a question, ma'am. In this patient, like you had before the final shoot, you had a left circumflex which was pinching. What could have been the expected outcome or result if you would have done an FFR in that side? And in all probability, the FFR would have been negative. So would you leave that alone? Because as per Korean data, majority of side branch pinchings are because of carina sheets, and leaving them alone would not harm the patient. It is as good or as bad as doing something. So if you would have done an FFR in place of OCT, how would it have changed your management? And what is the panel's view on this? Whether we should do a imaging on the side branch if there is a pinching, or you just do a FFR and just move away?
Yeah, your point, it's a good point, but at the beginning, we need to remember that the study that side branch FFR evaluation after professional stenting, which found pinching, it's not exclusively evaluate circumflex. It also include in patient with pinching diagonal and also OM, obtuse marginal. And for these cases, particular cases, because the patient is high bleeding risk, the gel strat could be as a nidus for thrombus, and we want to reduce that risk. But I agree with you, doing FFR probably is a good way, another strategy. But for this case, is just to reduce the risk for thrombosis for the nidus, and also to facilitate if in the future we need to treat the circ. It's my... Okay, thank you.
Thank you.
Can we see the result on the screen? Okay, so to finish the session, we are going to call for the winner. The winner is Mila with the presentation changing the treatment paradigm. So it's time to finish. Thank you very much to all presenters for for sharing these cases, and the panel and the audience for the participation. Thank you very much.